Nano, dengar tak suara saya? Nano, dengar tak suara saya? Hello? Cuba awak cakap.
Hello.
Okay.
Assalamualaikum.
Waalaikumsalam.
Salam, Doktor.
Waalaikumsalam.
Okay, how are you all?
Alhamdulillah.
Okay,
How are you,
okay.
Doktor?
Alhamdulillah, fine. Okay, so let's see before we start. Okay, can start now. Zurain, I can't hear you. Zurain, I can't hear you.
Hello, can
Hello,
anyone hear me?
yes, I hear you now.
Okay, Assalamualaikum warahmatullahi wabarakatuh to everyone. Today I will present about acute kidney injury. Okay, so acute kidney injury, which previously used to be called as acute renal failure. So for my outline today, I'm going to talk about 6 topics, which is the definition, classification, etiology, clinical manifestation, investigation, and lastly management. So let's start with number 1, which is definition. What is acute kidney injury or AKI? According to PITS protocol, this is an abrupt rise in the serum creatinine level and decreased GFR resulting in inability of the kidney to regulate fluid and electrolyte balance. While in Nelson, stated that it is a clinical syndrome in which a sudden deterioration in renal function result in inability of the kidney to maintain fluid and electrolyte homeostasis. Basically, to make it easier to understand, there are 3 things that you can say to define AKI. Which is number 1, it is an abrupt condition or rapid condition, in which number 2, there is decline in the renal function, which we evidenced by the level of creatinine and also GFR. And number 3, as a consequence of that, it leads to the kidney inability to do its normal function, which is to regulate fluid and electrolyte. Okay, so next, this is basically Schwartz formula. What Schwartz formula do is that we use this formula to estimate GFR in children. The equation are based on GFR might equal to K, which is K is the value that we take according to the age of the pediatric patient, which have been listed below, times the height of the patient, divide by the serum creatinine, and that's how we can get GFR, estimation of the GFR in the pediatric. Okay.
From where this one, Zurain? From where?
From where? From up to date.
from up to date. I think they are using the different units from Malaysia. They are using American units. So K in Malaysia, because in Malaysia you use micromole per liter for creatinine and millimole per liter for urea. So K in Malaysia equal 40. That's K in Malaysia. If you go during your housemanship, you want to calculate the GFR, K equal 40. Okay?
Okay, I will correct it later.
Yeah, add it later. Add it before you share again.
Okay. And then next is for the application to standardize the definition of AKI. Basically, there are three classification, which is modified P rifle, acute kidney injury network, and KDIGO. So let's start by the number one, which is modified P rifle, which stands for pediatric risk injury, loss, and stage renal disease. What does it? Why does it we call it modified? Because this is the pediatric modification of the adult rifle classification. So it's basically very simple. It consists only two. To assess the severity and outcome. The severity is by the three-graded level of injury of RIF, which is R, risk for renal dysfunction, I, injury to the kidney, and then F is failure of the kidney function. So to assess the severity of the AKI itself, we must the value that is given is the creatinine clearance and also urine output. But we can choose any. It's not N, it's not creatinine level and urine output, but creatinine level or urine output. Okay, and then two outcome measure, which is L and E, which is L for loss of kidney function and E for end-stage renal disease, which is differentiated by the number of the duration of the failure itself, which is more than 4 weeks or more than 3 months. Okay, that is simple. The next is acute kidney injury network, which is a criteria that is defined as more than 0.3 milligram per deciliter increase in the serum creatinine within a 48-hour period. So it can be divided into stage 1, stage 2, and stage 3. And in which stage 2 and stage 3 there is appropriate increase in serum creatinine over the stage 1. However, this criteria have many limitations in which it is not adequately validated, and also it only have a limited 48-hour time frame. Okay, that is why the most recommended classification that we want to use is this one, which is kidney disease improving global outcome, or KDIGO. So KDIGO, what happens that KDIGO combine the definition from the rifle, P rifle, and also akin in this single table. So basically it combine the serum creatinine level from the akin itself, which is within 48 hours, and also increase in serum creatinine level also, which is within the 7 days, and also urine volume. Okay, which can be divided into stage 1, stage 2, and stage 3, which is very simple. Okay, so basically that's it for the classification.
P
Now,
Rifli. P Rifli is the famous one. You can memorize P Rifli. This is the famous one used here in Malaysia, used in my country, and I think it is more famous than the other. P Rifli, the first one. Okay. Yes, carry on.
okay. Next is etiology or causes of AKI, which can be divided into three, mainly pre-renal, renal or intrinsic, and also post-renal. So it's for easier to understand. Basically, pre-renal mostly due AKI due to inadequate perfusion, while renal due to the direct damage itself to the renal parenchyma, and post-renal is basically mostly due to the obstruction. Okay, so number one, what happened in pre-renal AKI is that there is a reduced blood flow or reduced effective circulation or perfusion into the kidney, which in itself lead to reduced GFR and then lead to AKI. So basically from PITS pediatric, PITS protocol, the causes can divide into 4, which is hypovolemia, which is self-explained itself, which is it can lead to decreased blood flow. Third, space loss, also decreased blood flow or decreased perfusion to the kidney, and then this cavity shock, decreased perfusion to the kidney, and then cardiac, which is when there is a reduced cardiac output lead to reduced perfusion to the kidney. Okay, so next is intrinsic renal AKI. Okay. In intrinsic renal AKI, it includes a variety of disorders. So many disorder can lead to intrinsic renal AKI. But basically, what all this disorder do is that it cause a direct damage to the parenchyma or dysfunction to the parenchyma itself. So it can be divided into many origins such as vascular, glomerular, tubular, and interstitial. For vascular origin, what happens is that all these disease lead to lead to macro and microvasculature of the glomerular itself. Meaning, for example, for thrombosis, it lead to renal artery obstruction, which eventually lead to ischemia, which eventually damage the renal parenchyma. Okay. And also in all these HUS and thrombotic microangiopathy eventually also lead to ischemia and then damage the renal. Okay. And then for glomerular, what happens in glomerular disease is that, for example, acute glomerulitis or PSGN or SLE, what happens is that they are, the pathophysiology is that they are always related to autoimmune insult to the direct insult of the autoimmune itself to the kidney. And then for tubular, what happens is that this also the same as vascular, which is the common etiology are ischemia. For example, prolonged perineal AKI with reduction in renal perfusion due to ischemia, or it could be a nephrotoxin, which is, for example, antibiotics or chemotherapy or contrast agent that affect the tubule directly, or sepsis due to reduced perfusion, and then ischemia. For interstitial, what happens that is a cell-mediated immune reaction, which infiltrate the interstitial, which can lead to fibrosis. Okay, so post-renal, for post-renal, it's also variety disorder, but the pathophysiology is basically only one, which is obstruction of the urinary tract. So for infants or neonates, the mostly due to condition of congenital, which is abnormality in the urethra or uretero-pelvic junction itself, okay, which lead to obstruction of the urinary from the urinary bladder. But for older children, usually it can be due to acute obstruction such as stones or tumor bladder or cystitis. So basically, if we relieve the obstruction, we can recover the renal function easily. So for
How
clinical
to relieve the obstruction? Okay, open question. How to relieve the obstruction?
For from what I know, can use ablation.
Can use
Ablation?
a version. How can you explain how?
I don't remember. I read it, but I don't remember.
Anything more easy? Any emergency operation more easy? Nephrostomy. If you have obstruction, you can do nephrostomy. Nephrostomy. So once the urine come out, So you protect the kidney, then you can manage. Yeah. So do the nephrostomy first. Later on, you can manage the condition.
Okay.
Okay.
Thank you.
Carry on.
Okay. For next clinical manifestation. So basically, important we take a careful history so that we can identify the underlying causes of the AKI itself. And just like the causes before this, clinical manifestation can also be divided into pre-renal, intrinsic, and post-renal. For post-renal, because we already talk about the causes of pre-renal, so for clinical features, we must also look for any clinical features that which you can say a risk factor of hypovolemia, which is or reduced perfusion to the kidney, such as vomiting, diarrhea, or reduced oral intake, and it must be also associated with oliguria or reduced urine output. Hypovolemia also reduce urine reduce kidney perfusion due to any sign of shock such as tachycardia, poor peripheral perfusion, or any symptom of infection that may suggest sepsis. So for intrinsic, because there is a variety of disease that is from the renal etiology itself, so we cannot say that the urine volume can be high, it can be low, or it can be normal, but it all depends on the etiology or causes. Basically, what we can suspect, what is that? Okay. So basically, what we can ask the patient is any precipitating factor that we can suggest the etiology, such as, for example, post-tuberous glomerulonephritis. We can ask for history of pharyngitis or history of vertigo a few weeks prior to the onset of hematuria or edema. Other example will be like complaint of fever or joint pain or rash, maybe associated with autoimmune disease, such as HSP or SLE. Also for renal, because it's a renal, so we must also ask for any sign of volume overload, such as edema or any crackles. PE. Okay. And then for post-renal, because it's obstruction, so urine output can be low or normal depending on the level of the obstruction. But we can do PE itself to look for any palpable mass or any distended bladder on examination due to hydronephrosis. And then we can also ask for any complication of AKI, because AKI obviously can lead to many complications such as encephalopathy, which is can be manifested by lethargy or drowsiness, any acidotic breathing or chest-stop breathing due to metabolic acidosis, as well as manifestation of each of the electrolyte disturbance such as hyperkalemia, which can cause paresthesia or numbness, or hypoglycemia, which can lead convulsion or tetanus, and then hyponatremia can also lead to convulsion. Next is for investigation. We can divide it.
Ryan, I will ask you one question. Go back to the electrolyte abnormalities. So, uremic encephalopathy, lethargy, drowsiness, acidotic breathing, deep, rapid, hiccup, and late stage Shin-Stokes breathing, manifestations of electrolyte disturbance, hyperkalemia, hypocalcemia, hyponatremia. Okay, I will ask one question, open question, not for you only, for all. If you have cancer patient, leukemic patient with leukemia, admitted and started chemotherapy, started prednisolone. So then the patient developed hyperkalemia, hyperuricemia, hyperphosphatemia, hypocalcemia, and metabolic acidosis. What's the problem?
Hemolysis syndrome.
Hemolysis syndrome. Very good. This is the answer. Yes. Hemolysis syndrome. So how to treat hemolysis syndrome?
Hydration.
Hydration. Very good. Why we need to hydrate?
to expel the toxic metabolites
Toxic
through the
metabolitis.
urine.
So what toxic metabolitis they are causing the problem?
High uric acid.
Yes, high uric acid. High uric acid from death of the tumor cells. You see the tumor cells when they die, especially if you have large mass. If you have T-cell leukemia, or you have large mediastinal mass, and you start prednisolone. So the tumor cells will die. When the tumor cells will die, anything inside the cell will come out. So potassium will come out. It will cause hyperkalemia. Phosphate, because it is intracellular also, will come out. It will cause hyperphosphatemia. Uric acid also, because intracellular, will come out. Hyperuricemia. But why hypocalcemia? Why hypocalcemia? Anyone? Open question.
Phosphate will bind to the calcium.
Is it because of the hyperphosphatemia?
Very good. Because there is hyperphosphatemia, so phosphate is deposited in the tissue and phosphate bind to the calcium. So phosphate and calcium are deposited in the tissue. Very good. Correct answer, 100%. Okay, carry on. Continue.
So next is for investigation, which can be divided into blood investigation, laboratory urine investigation, imaging, and others. So number one, for blood investigation, there are many laboratory abnormalities which include number one for blood count, which we can see anemia, which is usually due to dilution or any hemolytic anemia, such as in SLE or renal vein thrombosis. Leukopenia or low white blood cell, you can see in sepsis, or low platelet, also in autoimmune disorder. Okay, for renal profile, which is the most important one, to indicate the AKI, we can see elevated creatinine, urea, as well as electrolyte imbalance, such as hyperkalemia and hyponatremia, to indicate the decline in the renal function itself. So for metabolic acidosis in atrial blood gases, as well as serum electrolyte, which is hypocalcemia, which is usually packed with hyperphosphatemia. Any other blood investigation such as serum C3 to look for any underlying etiology, anti-nuclear antibody, and also anti-septolysin titer for glomerulonephritis. For next is urine investigation or urine analysis or UFIM. Basically, the presence of hematuria, proteinuria, red blood cell CAS usually suggest any renal or intrinsic AKI, such as glomerular disease. While if there is a white blood cell or white blood cell CAS in the urine, combined with hematuria and proteinuria, will suggest tubular interstitial disease. While for urinary eosinophils, we can see that in the urine, it may due to drug-induced nephritis, but usually if the children have pre-renal AKI, urinalysis usually will be normal.
Wait, regarding urine FEME, there are certain urine investigations you can do which differentiate between pre-renal and renal. Can you tell us what investigations you do in the urine? Compare between pre-renal cause and renal cause. Open question. Anyone can answer?
Is it suprapubic aspiration?
What your what?
Is it suprapubic aspiration to assess for UTI? So from that we
No, I am not talking about the specific cause. I want something to tell me that this is pre-renal or renal. Anyone read from Nelson textbook? Okay, let's go to the whiteboard.
Is it specific gravity?
Yes. I hear specific gravity. Very good. Yes, tell me.
Yes. Ada.
Yeah, tell me, please. Yes, so specific gravity. If pre-renal, how it will be?
Pre-renal, usually the urine will show elevated
Very
SG.
good. If pre-renal, the urine specific gravity will be high, more than 1.5.
1.02. Okay.
Yes. Okay, or more than 1.02. Okay. If it is renal, it will be less than 1.010.
1.01.
Yes, very good, very good. So urine specific gravity is 1. Another thing. What about urine osmolarity and urine sodium? Can you tell
Urine.
me? Yeah,
So
tell me over the question.
pre-renal, elevated urine osmolality more than 500.
Yes, yes.
And urinary sodium will be low, less than 20.
Yes, correct. So if it is pre-renal, urine osmolarity will be more than 500 millimole per liter. Urine sodium will be less than 20 millimole per liter. Fantastic. If it is renal,
Less than 350 for urine osmolality.
very good.
For the sodium, it will high, more than 40.
Very good. Failing kidney, sodium comes out. Failing kidney, see, it is common sense. The good kidney is able to concentrate the urine. When you have good kidney, which has injury, your urine will be very concentrated and you will not lose the salt. So this is what happened to the kidney. The specific gravity and osmolarity will be high because the kidney still can concentrate the urine. And the sodium will be low because it will not lose. If it is intrinsic, the kidney will lose the sodium. So sodium becomes high in the urine and the kidney is not able to concentrate the urine. So specific gravity and osmolarity becomes low. Okay, one more. Tell me about fractional excretion of sodium.
So fractional, based on Nelson, fractional excretion of sodium, if it's pre-renal, we take less than 1%, but in neonates, we take less than 2.5%.
Very good, very good. If renal?
So for intrarenal, if we take more than 2% generally, but in neonates, we take more than 10%.
Very good, fantastic. Very good. Okay, now last thing. Now you are getting distinction. More distinction. Can you tell me how to calculate fractional excretion of sodium? How to calculate fractional excretion of sodium?
Sorry, I don't know.
Oh, no. Okay, so you stay only with the normal distinction. Okay. Who wants to get extra distinction? Fractional excretion of sodium?
Nelson, doctor.
Yes?
So urine sodium divided by plasma sodium
Very good.
divided by urine creatinine over plasma creatinine times 100.
Very good. Correct. Yes. So like you said, urine sodium over plasma sodium. You said divided by urine creatinine over plasma creatinine. Yes, correct. Some people make it different. They say urine sodium over plasma sodium times plasma creatinine over urine creatinine. So it is the same. It is the same. Then times 100 like you said. Very good. Fantastic. Okay, carry on.
The next investigation is for imaging. For chest plain radiograph, usually we do it to reveal any fluid overload symptom, any fluid overload signs such as cardiomegaly, pleural effusion or pulmonary congestion. While for renal ultrasound, usually for post-renal etiology, in which we want to see any urinary obstruction, which can be revealed by hydronephrosis or hydroureter, Nephromegaly is for if the disease is due to intrinsic in the disease itself. You can also do an urgent renal ultrasound if we cannot find any clear etiology of the causes of the AKI in the children. So for others, it's important that we do ECG because hyperkalemia can lead to cardiotoxicity, as well as renal biopsy, but also for any unprecise.
Yes, I will ask cardiotoxicity due to hyperkalemia. So now those who attended the lecture of hemodynamic monitoring, can you tell me what happened in the ECG? If there is cardiotoxicity from hyperkalemia? What happened?
In the ECG?
Yes, what is the change in the ECG?
This one. ECG changes in the hyperkalemia.
So first one, tall beaked T wave. Tall beaked T wave. Okay, that is hyperkalemia. If hypocalcemia, what will happen?
Hypocalcemia.
Who has good long-term memory? We mentioned in the lecture of hemodynamic monitoring. Okay, I remind you, hyperkalemia changes in the T wave in hyperkalemia, same like hypocalcemia. It changes in the T wave for hypokalemia, same like hypercalcemia. So the hyper at one side, same to hypo at the other side. So in other words, if we have hyperkalemia, we have tall beaked T wave. If we have hypokalemia, we have flat T wave. If we have hypercalcemia, we have flat T wave. If we have hypocalcemia, we have tall beaked T wave. Okay? Carry on. Which lead we use when we monitor ECG? Which lead? Which lead typically do we use when we monitor the ECG? Yes, who will tell me?
The rhythm lead?
Yes, lead?
Lead 2.
Lead 2.
Lead 2, very good. And then when you monitor by lead 2, if there is suspicion of abnormality, what will you order? You order 12 leads ECG. Yes, very good, 12 leads. So you monitor by lead 2, and if there is any abnormality, you order 12 leads ECG. Okay, good. Carry on.
Lastly, the management. For management of AKI, the principles are we must always start with prevention of AKI before the AKI happen itself, and then treat the underlying cause, and must always ensure that we can limit any additional renal injury to the kidney, and also if we must have give any medication, we must adjust the dosage according to the renal function. Okay, so number 1, prevention. For prevention.
Okay, can you go back? Go back to the previous slide. So treat the underlying cause. If you have one patient, open question also. If you have one patient with spina bifida, what will you do to prevent AKI? Yes, open question. Patient with spina bifida.
Maybe put patient on catheter because we expect patient of spina bifida will have neurogenic bladder, so it cannot.
Very good. Very good. Your answer is correct. Yes. Neurogenic bladder. Patients with spina bifida, they have neurogenic bladder. So do you want to use the catheter? How to use the catheter? Tell me how to use it.
Sorry, how to use the catheter?
Yes.
We insert the bladder catheter. We perform the bladder catheterization to the patient, and then afterwards we can consider to train the bladder by clamping for a period of intermittently, so that we want to train the bladder to pump.
You see, you cannot train the bladder because there is no nerve supply. Whatever, there is nothing. So the neurogenic bladder in spina bifida is lifelong condition. The catheter, so I want you to say, I use CIC. What is CIC? CIC means clean intermittent catheterization. Clean intermittent catheterization. So, especially if the patient has good upper limbs, because many patients with spina bifida, they have normal upper limbs. They have normal upper limbs. So, we can advise them, they take the catheters to the home, disposable catheters, not fully catheter, the other catheter, which is like NGT. They take to the home, and even they can't go to the work by the wheelchair, but they have to take their bag, having the catheters and having sterile gloves. So they must be sure that when they open the catheter, they don't contaminate. They wear sterile gloves and insert the catheter. They can use gel and insert the catheter every 4 hours. They can go to the toilet by their wheelchair and then insert the catheter, evacuate the urine out. They need to do that for life. We start since birth and we continue for life. We must be serious to protect recurrent UTI. Otherwise, they will get recurrent UTI and then they will get acute kidney injury. They will end with the chronic kidney disease and then they will require transplant or they will die. So we must be careful. So another thing for those with the neurogenic bladder, we use oxybutynin. OXYBUTININ. OXYBUTININ. This oxybutynin is anticholinergic. Anticholinergic. This anticholinergic will improve the bladder storage capacity. So patients become very happy when you use oxybutynin. Why? Because many of them, they have improved the bladder storage capacity. They will have no dribbling. They will have no dribbling. So every 4 hours, they just go to the toilet, insert catheter, urine come out. So no more dribbling. No more dribbling. Because without that, you know, neurogenic bladder, you have two problems. You have retention and you have dribbling. Because the bladder is not functioning. Nervous, not functioning. No nerve supply to the bladder. So the bladder becomes like just if you have some structure that is fillable and at any time it leaks out. It gets filling, storage inside, stasis, then suddenly leak because no nerve supply. But when you use oxybutynin, so the oxybutynin will work on the muscles, it will cause muscle relaxation, so the bladder storage capacity will increase, and then the patient have no leak. And every 4 hours, patient go to the toilet, use the catheter, so the urine will not stay in the bladder. Then we can maintain good kidney function by preventing the urinary tract infection. Because without that, it is easy to get UTI. Like if you have a swimming pool, the normal swimming pool, the clean swimming pool, the water is not static in the swimming pool. The water must renew. Every time renew. So it will be clean, then we can swim inside. But if you take swimming pool and keep the water stagnant, no renew, day by day that swimming pool will be foul, smelly, greenish color will be very dirty. So this is what will happen inside the urinary bladder of spina bifida. If we don't do CIC, the urine will accumulate, then it will be dirty. It is good media for bacteria. Is it clear? Okay. So carry on.
Okay, so for next management, number one is prevention. It's important to identify the patient at risk of AKI, which includes the following patients such as the premature babies, the asphyxia, or the trauma patient, or patient with burns or post-surgery, or any other organ failure, or pre-existing renal disease, or any malignancy. So what happens is that we will monitor this patient at risk actively, which we will monitor their renal function and urine output. So that we can ensure any non-diuretic measure that is effective, so that we can restore any renal blood flow, avoid any agents that can toxic to the kidney, as well as maximize renal perfusion before any exposure to the toxic itself. Okay, so that is prevention. For number two is management of AKI is by fluid balance, which we have three fluid situation, which hypovolemia, or euvolemic. So in hypovolemia, whatever happens that we must always do fluid resuscitation, regardless whether the patient is oliguric or non-oliguric. Okay. So basically our option is must always be a crystalloid. Crystalloid that we will give at 20 ml per kg fast bolus in less than 20 minutes. And also we can, other option is that we can give bloods if the hemorrhage is the cause of the shock that lead to AKI. So basically after volume resuscitation, usually hypovolemic patient generally generally will void within 2 hours, but if there is no urine output for about 4 hours after that, we monitor the central venous pressure to assess the fluid status. So for hypovolemia, what happens is that because of the fluid overload, what we must do is we must do a restriction of the fluid itself, and also give diuretics to correct the fluid overload. And also we also other things that we can do is we monitor the features of volume overload, such as hypertension, raised JBP, circulation, hepatomegaly. And if there is no response to any fluid restriction and diuretics, we must think of dialysis, so that because we don't want it to be life-threatening overload.
You mentioned if hypervolemia, fluid restriction, and furosemide, 2 micromilligram per kilogram per dose over 15 minutes. If have to give fluid, restrict to insensible loss. How to calculate insensible loss?
Usually 400 ml per millimeter squared per day.
Yes, very good. Correct answer. 400 ml per meter square per day. So depend on the surface area. So how to calculate the surface area? Okay, open question. How to calculate surface area? Yes.
If we take the height and weight, yes, the square root of weight times height.
Yes.
Over 3,600.
Very good. Very good. Very good. It is correct. It is correct. Okay. Can you repeat again?
It is the square root of
Uh-huh.
width times height.
Mhm.
Width in kg, kilogram, and height in centimeter.
Yes.
And then divide by 3,600.
Correct. Fantastic. Fantastic. Yes, it is like this. Yes, it is square root of weight by kilogram times height by centimeter divided by 3,600. Correct. That's the body surface area. So, and the insensible loss is equivalent to 400 ml per meter square. So, that's the insensible loss which we need to give, whatever, even if we don't have urine coming out. So, normally, if you want to do an experiment, if you know your body surface area, if you want to do experiment on yourself, you drink, you calculate the amount which you drink, and then calculate your urine. After that, minus. Always, if you drink well, if you drink the right amount, you will have more drinking than urine output. Should be more, should not come out all. Why? Because you have some comes by insensible loss, which is 400 ml per meter square. For example, my surface area is around 2 meters square. My surface area is around 2 meters square. If I drink 2000 ml every day, if I drink 2000 ml, so I urinate 1200 ml. Normally, I urinate 1200 ml. 800 ml must stay for insensible loss. Sweating and respiration, that's insensible loss. If body surface area is 1 meter square, and for example, you drink 2000 ml, so what will come out is 1600. 400 will stay in your body because it will come out by insensible loss. It will not come out as urine. Clear?
Doctor, I have a question.
Yes, yes, please.
If the child is on diapers, how actually we can quantify?
How?
If the child is on diapers.
Diapers, yes. Very good question.
How
How
to know that there is
quantify the urine? Okay, very good. Yes, you see, what we do in the ward, if we are not inserting catheter, we ask the nurse to weigh the dry diapers and weigh every time after urination, and we take minus. So the dry diapers we minus from the wet diapers, and normally 1 gram urine equal 1 milliliter. 1 gram urine equal 1 milliliter. The only problem for this calculation, if the baby has urine and stool at the same time, then it will be difficult. If the baby passes urine and stool at the same time, then this method will not be accurate. So in that case, if you are very concerned, you must insert catheter in the ward. Insert urine catheter, so you'll have the accurate calculation.
Sorry, Prof, can I ask a question?
Yes.
Do we use like the urine bag whereby they put sellotape on the side on the ground to collect the urine?
A urine bag to collect the urine. The problem urine bag may, it has some blaster which may come out. It help you, but if the child is moving a lot, it may come out, then it will spill in the diapers. If you are very concerned and worry about your patient that his condition is serious, better insert catheter.
Okay. Thank you, Prof.
Welcome.
Thank you. Yeah.
Thank you. Carry on.
Okay, so next, for euvolemia is when the patient has already achieved normal volume status. What we can do is we just monitor the fluid status to see if any
in this case, you give insensible loss plus ongoing loss. If euvolemia, you give insensible loss plus ongoing loss. Insensible loss, like we said, 400 ml per meter square. Ongoing loss, you see. If any urine come out, you give it. 20 ml urine came out, you give the patient 20 ml. It is like this. It is like this. Okay.
Okay. So, next for managing complication, which mainly due to electrolyte abnormality or imbalance. For hyperkalemia, usually it defined by more than 6 millimole in neonates or more than 5.5 millimole per liter in children. If for cardiac toxicity, which can be we can see if there is a cardiac arrhythmia or cardiac arrest or even death, usually develop when the potassium is more than 7 millimole per liter. So before that, we must, that's why regardless of the degree of the hyperkalemia, we must always initiate treatment, especially if there is ECG abnormality. So basically from the table itself, the treatment of hyperkalemia is by using a lactic cocktail, which is the calcium gluconate, dextrose, insulin, salbutamol, and polystyrene sulfonate. So for hyperphosphatemia,
Let's go to hyperkalemia. Hyperkalemia is very important. Hyperkalemia is very important. Okay. So when you see patient with hyperkalemia, what is the first medication you will choose?
Calcium gluconate, Prof,
calcium
for
gluconate.
cardioprotection.
Very good. Calcium gluconate for cardiac protection. Calcium gluconate, if the level becomes more than 7, yes, you need to use calcium gluconate. Does not mean that it is the first one. Depending on the hospital protocol, usually they use insulin and glucose first. But calcium gluconate is very important for cardiac protection, like you said. How it protects the heart, calcium gluconate?
Sorry, Prof, I forgot.
You forgot. Okay, very good. Anyone remember how calcium gluconate protects the heart?
Increasing the threshold potential. Calcium can increase the threshold potential because in potassium there will be the base potential will be elevated, so easier to be to get the nerve impulse conduction. So the calcium will heighten up the threshold potential to initiate the impulse.
You see the calcium when you see the potassium channels or sodium channels, what we call them voltage gated. So the calcium like the guard for these channels. So if you have good calcium, it will guard the potassium channels, so it will protect the cardiac membrane. So like a guard for the potassium gates. Okay. How insulin and glucose work? Open question. How insulin and glucose work? Which one lowers the potassium, glucose or insulin?
Insulin.
The insulin, yes. How insulin lowers potassium?
Insulin will make the potassium to go into the cell.
Very good. Correct answer.
Together with the glucose. That's why we need to give glucose, because patients tend to get hypoglycemia.
Very good. So correct answer. Insulin will move the potassium inside the cell, and you give glucose to protect the patient from hypoglycemia. Very good. How insulin moves potassium inside the cell?
By blood or blood transport.
Yes. By stimulation of Which pump? Which pump is stimulated by insulin and by salbutamol?
Sodium potassium pump.
Very good. Sodium potassium ATPase pump. Sodium potassium ATPase pump, which push potassium, 2 potassium inside and pulls 3 sodium outside. So this pump is stimulated by insulin. Stimulated by insulin. Okay, and like you said, you need to give glucose to prevent from hypoglycemia. So now we know the mechanism of action of calcium gluconate, glucose and insulin, and salbutamol. Okay, what else? Sodium bicarbonate. How sodium bicarbonate? How sodium bicarbonate works?
Help in intracellular uptake of potassium.
Helps in intracellular uptake of potassium. Okay, is there any other way? So what sodium bicarbonate do for the pH? Sodium bicarbonate will take pH toward alkalitic side or acidotic side?
Alkaline. Alkalinizing.
Alkaline. So it will take the pH toward alkaline side. So this will reduce the potassium, because always when you have acidosis, you have hyperkalemia. When you have alkalosis, you have hypokalemia. Except 2 conditions. 2 conditions only have acidosis and hypokalemia. Always, always. If you see acidosis, it is hyperkalemia. Alkalosis, hypokalemia. Only 2 conditions have acidosis and hypokalemia. So who will get distinction? Yes, yes?
Diabetic ketoacidosis.
Very good. Diabetic ketoacidosis and
I'm not sure that. Give a second.
renal tubular acidosis. Okay. Then what about calcium polystyrene sulfonate? How does this work? Calcium polystyrene sulfonate. This is by GIT excretion. It is slow working. It works slow, but the work by calcium polystyrene sulfonate by excretion GIT is a good. It is good. It is slow, but effective in reducing the serum potassium. What about furosemide? You did mention furosemide. What about furosemide? Okay, open question. How furosemide reduce serum potassium?
It can lose potassium in urinary excretion.
Yes, prevents increase potassium excretion where?
At the
Increase potassium excretion in urine prevents absorption of sodium and potassium and 2 chloride in the ascending loop of Henle. That's why we call it loop diuretic. We call it loop diuretic because it prevents absorption in the ascending loop of Henle. Sodium, potassium, and 2 chloride. So you see, some theoretical points we leave, we don't pay attention, but hyperkalemia is important. Hyperkalemia, you can get questions in the exam, especially if you do well. If you do well and they think to give you distinction, they will start asking you. MCQ questions, it may come. Hyperkalemia is important. Why? Because hyperkalemia is dangerous and can kill the patient. That's why we ask in the exam, if something is very serious, you need to know, yes. potassium is dangerous, can kill the patient. If you inject potassium in the patient will die. If you go to the patients who have hypokalemia, those with low potassium, we correct by infusion. We give potassium by infusion. We don't give injection. It is not like glucose or calcium. If you have hypocalcemia or hypoglycemia, come, bolus glucose, bolus calcium. But potassium, we never give bolus. Even hypokalemia, we never give bolus. If you give bolus, cardiac arrest, and patient will die. So you have to be very careful. Okay? Carry on.
So for next complication is hyperphosphatemia, which we can treat by giving low phosphorus diet or using any phosphate binders such as calcium carbonate. And hypocalcemia, we primarily we treat it by lowering the serum phosphorus level. But if we cannot do that, we can give oral supplement, which is calcitriol, which can help our body to absorb calcium. Okay, and if severe, we can use calcium carbonate.
Okay, hypocalcemia, there is an important question you need to know, especially during your housemanship, and they ask you in the exam also. Anyone know what is the corrected calcium, corrected serum calcium?
Is it?
The album.
It's okay. Daya jawab dia.
Yes.
Jawab
Anyone
aja.
knows correct? Yes.
Okay, I'm sorry. I thought Daya wants to answer. I think something about minus. We have to minus the amount of the albumin because it gives us the wrong actual value of the calcium. But the
Very
formula,
good. Formula, yes.
I think for the formula, I'll pass to Dahiyah to answer the question.
Yes, Daya.
40 okay. 40 minus patient's albumin and 0.02, and then we add up with the patient's serum calcium. So we correct it.
Okay, let's do one example because this is your work during housemanship. We go to the whiteboard now. Okay. Okay, let's say you have one patient, serum. Can you see? Serum albumin. $25 grams per liter. And you have serum calcium 1.8 millimole per liter. And we know that 1 gram per liter albumin binds 0.02 millimole per liter calcium. Millimole per liter calcium. So I give you example. This one. Serum albumin 25, serum calcium 1.8. Corrected calcium equal measured calcium plus 0.02 times 40 minus albumin. Measured calcium plus 0.02 times 40 minus albumin. Can you all work it and tell me the result? Use your calculator and tell me the result.
I got 2.1.
2.1. Very good. Wajiha, yes. Correct answer. 2.1.
Yes,
Did
doctor.
you get the same result? Others, did you get the same?
Yes, doctor.
Yes, doctor.
Very good. Very good. Okay. We'll go back to the slides.
So next is hyponatremia. Usually for hyponatremia, usually due to dilutional from the fluid overload. So rather than we give sodium chloride to correct the sodium, we usually just restrict the fluid to correct the sodium level. And but if there is symptomatic or any above measure is failed, like fluid station is failed, then we can give sodium for dialysis. For next complication of AKI is that metabolic acidosis. Really we usually don't require treatment if it's a mild form, but if the pH is too acidosis such as less than 7.2, or if the patient having symptom contributing to the hyperkalemia, then we can give patient bicarbonates 8.4% with 1.1 dilution sodium bicarbonate, and also to replace half the deficit with IV sodium bicarbonate. After that, we can monitor the blood gases to see if there is a correction or not. But we must ensure that we don't rapidly correct metabolic acidosis, because rapid correction can lead to tetanus due to reduced calcium concentration.
Again, can you repeat what you said?
When treating the metabolic acidosis, we must ensure that we don't rapidly correct the metabolic acidosis, because it can lead to tetanus due to effect of calcium concentration reduction.
This is very important. This is very important. Also, question of distinction. Who wants to get distinction? Anyone can explain what will happen? And practical point, yes. Yes. Okay, we go to the whiteboard. We go to the whiteboard. So like I said, we have to be sure serum calcium more than 1.8. In other words, if you have hypocalcemia and acidosis, don't treat acidosis first. Please treat hypocalcemia first. If you are a doctor who does not study, practice without study, he may make the mistake. He may correct the acidosis first and cause harm to the patient. So please study, and you must know we treat calcium first. You see, calcium total calcium, when we have total calcium, we have 50% bound to albumin, and we have 50% free. The free calcium is ionized. The free is ionized. This one is not ionized. The free is ionized. It has two charges here. Ionized. And this is the important. This is the strong one. This is the strong calcium. Imagine buffalo. Buffalo with horns, buffalo without horns. This one albumin bound to albumin, buffalo with no horns. Cannot do anything. Yeah, because we know the buffalo is dangerous by his horns. These two charges of the calcium are the horns of the buffalo. It will be very strong. Can kill you. Can kill everyone with the two charges. So strong calcium by the charges. This is the one which is important. The other one is not physiologically important, bound to albumin. We need the ionized calcium. Our ionized calcium is the important one. We need ionized calcium. It is the strong one. It is the buffalo with horns. It is the strong calcium. So, if I have acidosis, means I have increased hydrogen ion. Hydrogen has one horn. Hydrogen. Allah subhanahu wa ta'ala created our body, and always, rahmatullah subhanahu wa ta'ala, try to protect our body. Even when we get disease, gives us a chance to recover and not to die by the physiological responses. So the physiological response, when we get acidosis, we will not die immediately. Allah subhanahu wa ta'ala will make this hydrogen go to albumin. Go to bind to albumin. Bind here. How to bind to albumin? If this is albumin, and it has calcium here, and calcium, so hydrogen will come. Hydrogen will come to attach here, and then it will replace, go away calcium. Calcium will go away from here to the ionized calcium and give its place to hydrogen. So in fact, acidosis is good for the calcium. It maintains ionized calcium. As you get acidosis more, you maintain ionized calcium. Calcium leaves albumin and goes free in the circulation. Calcium with the charges. Buffalo with horns. If you treat acidosis, no more hydrogen ions. So, if you treat the acidosis, no more hydrogen ions, you are giving a chance for this hydrogen to go out to the blood. So what happened to its place? The calcium will come from there. The ionized calcium will come from there and attach to the albumin. And then the good calcium will drop. The calcium with two horns. Then we go to tetany. Is it clear?
Doctor, can you repeat after we treat the acidosis?
Okay, after we treat the acidosis. Okay. Okay, so let's say we have this albumin and attached to it calcium and calcium and calcium and hydrogen. If I have acidosis here, high hydrogen, I treat. When I treat, so means hydrogen will become low. So my body does not want to become alkalotic. Does not want to go to alkalosis. So what will happen? The hydrogen which is bound to albumin will go there to balance the pH. Balance the pH. Balance pH. Then this place of hydrogen will be empty. Albumin will not keep it empty. Once it becomes empty, albumin will attract the ionized calcium. So the calcium will come here. And then this ionized calcium will drop. And this is the physiologically important. In fact, you didn't lose calcium. You still have the same calcium. But the problem, the calcium which you have now has no charges. Like the buffalo without horns. You need your calcium to have the charges. You need your calcium to be free. Have two charges like buffalo with two horns. Is it clear?
Okay, yes.
Okay. So we continue with the slides.
Okay, so lastly, for hypertension, mostly due to fluid overload or it can be due to renin action. Choice of treatment will be antihypertensive, which is diuretics to get rid of the fluid overload. Okay. Next, management is nutrition because optimal intake in AKI is influenced by the nature of the disease that cause the AKI itself. So generally, nutritional requirement of patient with AKI apply except that they need to avoid any excessive protein intake or any excessive fluid intake if applicable, and minimize any phosphorus and potassium intake, as well as if GI tract is not intact, is still intact and functional, we can start enteral feeds as soon as possible.
Why avoid excessive protein? Why we need to avoid excessive protein?
To reduce stress to the kidney.
Yes, burden on the kidney, because the kidney will metabolize the protein. Yes, so reduce burden on the kidney. Very good.
Okay. Lastly, for dialysis, usually indicated for only for life-threatening complications such as fluid overload, electrolyte imbalance, symptomatic uremia, or symptomatic uremia. Basically, there are a mnemonic that we can use to easily remember the indication of dialysis, which is AEIOU for acidosis, electrolyte for hyperkalemia, intoxication or overload of fluid, overdose of the drugs, as well as uremia, AEIOU. Okay, so there are three options, usually three options of dialysis: peritoneal dialysis, intermittent dialysis, and CCRT, which is the most common one that the pediatrics use are the peritoneal dialysis. So for prognosis, the mortality rate of children with AKI is variable, and it depends on the underlying disease itself. Basically, if it's due to the renal limited condition, is very low mortality, while if there is AKI with any other organ failure with high mortality, which more than 90%. And also prognosis for recovery of renal function, most likely recover if it's the disease that is caused from the pre-renal cause, while not usually recover if the disease is rapidly progressive or thrombosis or any disease that can lead to ischemia or necrosis of the kidney itself.
Exactly.
Okay.
Exactly. Yes.
Okay.
So the disease is reversible, and you are good doctors who study well and apply what do you study. Your patient will survive. Your patient will recover kidney function. If the patient is unlucky, like his disease is progressive, his condition is untreatable, or the doctor is treating him, they don't study, then the prognosis will not be good.
Okay, that's all.
Okay, good. Any questions? Any questions to Ayn? So always remember, you need to know the corrected calcium. You need to know hyperkalemia. You need the serious situation when you have hypocalcemia and metabolic acidosis. Always remember calcium before acidosis. Correct calcium before acidosis. سمو أدا hypocalcemia. أدا acidosis. So rawatan hypocalcemia dulu. Hypocalcemia dulu. Jangan rawatan acidosis dulu. Rawatan hypocalcemia dulu. Okay? We can go to the next presenter. Try to be faster because at 5:15 we have meeting in our department, so we want to go faster.
Hello.
Yes.
Okay, Assalamualaikum warahmatullahi wabarakatuh.
Alaikum salam wa rahmatullah.
So I will present about chronic kidney disease. My name is Sahil. So this is my outline. Okay. So definition of chronic kidney disease is according to Nelson, it is determined by the presence of kidney damage and level of kidney function, which is glomerular filtration rate, irrespective of the diagnosis. However, according to the KDOQI guidelines, CKD is defined as the abnormalities of the kidney structure function, which present for 3 or more months with implication on health. So from this table, we can see that the patient will diagnose as CKD when they have kidney damage for 3 or more months, either by structural or functional abnormalities with or without decrease in GFR, or they have GFR less than 60 mL per minute per 1.73 meter squared for 3 or more months with or without the signs of kidney damage. Okay. However, the prevalence of CKD in pediatric population is around 18 per 1 million. Okay. And then for etiology, in children, CKD can be the result of congenital, acquired, inherited, or metabolic diseases. And the underlying causes can be related to the age of the patient at the time when the CKD is first be detected. So in children less than 5 years old, it is most commonly due to congenital abnormalities such as the most common one is renal hypoplasia and dysphasia or obstructive uropathy. Or other causes can be congenital nephrotic syndrome, Purine syndrome, cortical necrosis, focus segmental glomerular nephrosis, renal vein thrombosis, or HUS.
Okay, 1 minute. What is Brown-Billy syndrome?
Brown-Belly syndrome is the partial or complete absence of the stomach, like the abdominal muscle also, and also the urinary tract also was malformation. There is malformation of the structures.
Yes. Yes. Yes, exactly. So the problem that Brown-Billy syndrome, they have the major issue. They call it Brown-Billy because the abdomen has no muscle and subcutaneous tissue. That's why if you look at the abdomen, you will see the intestine, visible intestinal movement, because no abdominal muscles. And they have renal anomalies. Which can lead to chronic kidney disease. And you mentioned renal vein thrombosis. Does renal vein thrombosis start as acute or comes chronic from the beginning?
Start from acute.
Start as acute. Now tell me, in pediatric age, what is the most common cause of renal vein thrombosis? Okay, open question. What is the most common cause of renal vein thrombosis in pediatric? Must be versus triad, is it? Something in versus triad. Yeah, abnormal wall, or abnormal blood, or abnormal flow. It will be abnormal blood hypercoagulability. What is the common condition in pediatric which can lead to hypercoagulability? You know it?
Nephrotic
Yes?
syndrome.
Nephrotic syndrome. Very good. Yes. Nephrotic syndrome. Very good. So how is the presentation? When patient has nephrotic syndrome, what will happen?
There will
What are
be
the symptoms?
hypercoagulability. Hypercoagulable state because of loss of antithrombin through the renal.
Very good. Yes, loss of antithrombin 3, loss of protein C, loss of protein S. Yeah. And also hyperlipidemia itself. All these lead to an hypovolemia also. Hyperlipidemia, hypovolemia, and loss of antithrombin 3, protein C, and protein S. All that contribute to renal vein thrombosis. How is the presentation, the clinical presentation? If you have one patient, nephrotic syndrome in the ward, then something happened to him or to her, make you suspect renal vein thrombosis as a complication. What are the symptoms, clinical symptoms?
Flankness. Flank pain.
Loin pain, and I hear that. What is the other thing? I heard from you.
Hematuria.
Hematuria, very good, and
mass.
Very good. So this is the presentation of renal vein thrombosis. Hematuria, mass, and loin pain. Very good. Carry on.
Okay, so after 5 years old, it can be due to acquired disease or inherited disorders, and also metabolic disorder. For acquired diseases, it can be from various forms of glomerulonephritis and also lupus nephritis. And from inherited disorder, it can be due to familial juvenile nephropathy, Alport syndrome, and polycystic kidney disease. And
okay, open question. Anyone knows Alport syndrome? What is Alport syndrome?
Syndrome where there is presence of sensory neural hearing loss and hearing impairment and visual impairment.
Very good. Very good.
Autosomal dominant.
Very good. Very good. So the kidney, the ears, and the eye. This is Alport syndrome. Very good. Okay, carry on.
Okay. So this is a stage of CKD. And then from the table, we can see that there are 5 stages of CKD. So, however, this classification can only apply for children from 2 years old and older. It is not applicable for less than 2 years old because their GFR is normally lower than the values of older patients' GFR. So it would be incorrect. So in children, This is from up to date.
Yes, yes, correct. Yes,
Okay.
yes, correct. Very good.
Okay, so and then for pathophysiology, we know that CKD has various etiologies, right? So, but the development of the kidney failure is somewhat similar in all etiologies. So mainly it is due to the injury of the kidney which cause loss of the nephrons. So firstly, there will be hyperfiltration injury. What happens is that when there is glomerular destruction, there will be loss of nephrons. So when nephrons are lost, the remaining nephrons will undergo structural and also functional hypertrophy, and then which can increase the glomerular blood flow. And after that, this causes increase in the glomerular filtration, and this filtration is called adaptive or compensatory hyperfiltration. And then even though that this adaptive hyperfiltration will preserve the renal function temporarily, it can also cause progressive damage to the surviving glomeruli. So it can due because of the direct effect of the elevated hydrostatic pressure of the capillary wall. So it will cause the wall to become sclerosed. Okay, and then so and then proteinuria can also cause decrease in renal function due to direct toxic effect to the tubular cells, as they will recruit the monocytes and also macrophages, and then when the proteins cross the glomerular capillary wall. So so this will further enhance the process of glomerular necrosis that happens, and also will cause tubular interstitial fibrosis. Okay.
Very good. Very good.
Okay. And then for hypertension, we know that hypertension will cause the arteries around the kidneys to become narrow, and then it will weaken and harden the vessels. So it can cause arterial nephrosclerosis and further increase the hyperfiltration injury. Okay. And then for hyperphosphatemia, when there is increase in phosphate, there will be increase in the progression of the disease, like you said before, which leads to calcium phosphate deposition in the kidneys and also the blood vessels. And then hyperlipidemia is the same, as they can affect the glomerular function by oxidant-mediated injury.
Very good.
Okay. Okay, so this is basically the summary of what I've said before. Okay. Okay, and then we move on to the clinical features of chronic kidney disease. Really, the clinical presentation of CKD is varied, depend on the underlying of the causes. But generally, children with CKD can present with pale and sallow appearance due to the deposition of the waste product under the skin, as they are failed to be excreted. And then they also can be they also will be growth disturbance or failure to thrive, neurotic, lethargic, they also can have polydipsia, polyuria, hypertension, reduced appetite, nausea, and also neurologic symptoms. And then, okay, if patient has chronic glomerulonephritis, they can present with edema, hematuria, proteinuria, and for congenital disorder, like I've said before, they can be failure to thrive, dehydrated, or even have UTI and overt renal insufficiency. And then for long-standing and untreated CKD, there will be growth restriction, and they will have short stature, and they will can also cause bony deformities due to renal osteodystrophy.
Okay, here there is an important question. Okay, distinction question. Renal rickets, renal osteodystrophy. Okay, if I give you the blood investigations, okay, I give you serum calcium, serum phosphate, alkaline phosphatase, and parathyroid hormone. So please all write in your notes serum calcium, serum phosphate, alkaline phosphatase, and parathyroid hormone. So if I give you three results, okay, let's go to the whiteboard. Okay, can you see the whiteboard?
Yes, doctor.
Okay. So we take three patients. First patient has normal calcium, low phosphate, high alkaline phosphatase, high parathyroid hormone. Okay, second patient, low phosphate also, normal calcium, high alkaline phosphatase, and normal parathyroid hormone. Third patient, low calcium, high phosphate, high alkaline phosphatase, high parathyroid hormone. Okay, so from these three, which one is the renal rickets?
Three.
Yes, which one?
Three.
Number 3.
Number three, very good, correct answer. Yes, so this is number three is the renal rickets. Why? Because they have high phosphate. They have high phosphate. Okay, so they have secondary hyperparathyroidism. They have secondary hyperparathyroidism, and their bones become weak because we have loss of calcium from the bones. We have loss of calcium from the bones. We know chronic kidney disease has hypocalcemia. Response to hypocalcemia, parathyroid hormone increase to compensate. So parathyroid hormone will increase the serum calcium from the bone. So the bone will release the calcium, but at certain point cannot compensate anymore. Calcium will stay low and the bone will be weak. So this is the renal rickets. What about first one and second one? Which one is nutritional? First or second? So this one is calcium deficient. The nutritional is here. This is calcium deficient rickets. This is calcium deficient rickets. This is the nutritional one. Why the calcium is normal despite the bones are weak? The calcium is normal because of parathyroid hormone. Parathyroid hormone is able to maintain serum calcium, and parathyroid hormone will make the phosphate low. In this case, in number 2, it is phosphate deficient rickets, like in Fanconi syndrome, phosphate deficient rickets. Phosphate deficient rickets. The difference is the parathyroid hormone. The parathyroid hormone is not increasing in phosphate deficient rickets. Example is Fanconi syndrome. Clear? If clear, we go back to the slides. Okay, we go back to the slides.
Okay. Okay, so we move on to investigation. So for laboratory investigation that can be done is firstly renal profile, where we can see the urea creatinine, it will be increased, and there will be also hyponatremia, hypocalcemia, hyperphosphatemia, and hyperkalemia.
So the same thing, yeah? The same thing which happens in the acute happens in the chronic. The same thing. Okay.
Okay, and then uric acid will be elevated. Okay, and then secondly, we can do full blood count, and normally patient with CKD will present with normochromic normocytic anemia due to reduced erythropoietin production, or can be IDA, or folate or vitamin B12 deficiency. Okay, and then lipid profile also will show elevated serum cholesterol and also triglycerides. And then in urinalysis, there will be hematuria, proteinuria, and low specific gravity, like Dr. has explained before. And then for glomerular filtration rate, the gold standard is actually inulin clearance, but it is a very difficult procedure to do in children, so we use the bedside formula. So in this one, okay, we change to the one that Dr. told us.
Yes. Yeah, 40. Malaysia 40.
Okay. And then lastly, we can do liver function test, and there will be hypoalbuminemia. Patient with proteinuria will have hypoalbuminemia. Okay. Okay. Then lastly, we move on to the management. Sorry. So the aim for management in patient with children with chronic kidney diseases is to treat the reversible kidney dysfunction, prevent or slow the progression of the kidney disease, treat the complication, and identify or prepare the children or family which renal replacement therapy will be required. So this is the principle of management. First, slow the progression, then assess the severity, then detect the complication and treat the complication, and then we prepare for kidney failure, which is dialysis or renal replacement therapy. Okay, so in management of CKD, it requires close monitoring of the patient's clinical and laboratory status, in which in blood studies we need to monitor closely the serum electrolytes, blood urea nitrogen, creatinine, calcium, and so on. And also we need to do predict measurement of parathyroid hormone, and also X-ray of bone, and then to detect the early evidence of osteodystrophy. And then echo also should be performed periodically in order to identify any cardiac complications of CKD, such as left ventricular hypertrophy and also cardiac dysfunction. And then, actually there is no definitive treatment of CKD, but we need to improve renal function in children. Okay. So what can be done is we need to treat the specific underlying disorder whenever possible lah. And then the first one we can give nutritional management, as anorexia and vomiting is very common in patients with CKD, so that when we give nutrition adequately, they will have energy for daily activities. So what can be done is by giving calorie supplements, which must be balanced between carbohydrate, fat, and also protein. And the protein intake should be sufficient enough in order to maintain the children's growth. But if the oral nutrition is not sufficient, so we need to consider tube feeding or gastrostomy, so that we can optimize the growth. Okay, and then for acidosis, we need to control the salt and water balance as well. Oh, sorry. And then with appropriate diet, most children can maintain the normal amount of sodium and also water, but in those with congenital abnormalities and also renal dysplasia, the children can be polyuric, so they will lose a lot of salt and water. So in this patient, we need to give salt supplements and give free access to water. And then according to Nelson, fluid restriction is actually rarely necessary for children with CKD, but if ESRF, end-stage renal failure develop, we need to give restriction. Okay, and then for bicarbonate similar is the same as AKI, as we need to treat the metabolic acidosis. Okay.
So if you have hypocalcemia with acidosis, which one you treat first? Hypocalcemia, always. Calcium dulu, calcium dulu. Okay. Carry on.
Okay, next one is prevention of the osteodystrophy. So in patient with renal osteodystrophy, that there will be hyperparathyroidism, which usually cause osteitis fibrosa cystica, which is the complication of the hyperparathyroidism itself, which the bones become deformed and very weak in those children. So in this patient, we should restrict the phosphate intake, for example, by decreasing the intake of milk products such as yogurt, milk, cheese, and because even though this food has high amount of calcium, they also have high phosphate content. And then we give also calcium carbonate as phosphate binder, so that there will be increase in the excretion of the phosphate. And activated vitamin D supplement can also be given in order to...
What do you mean by activated vitamin D? What do you mean by activated vitamin D? Yeah, open question. What is the meaning of activated vitamin D? Okay, open question. Yes.
Is the alpha calcidiol? So
is it?
The alpha 1 calcidiol.
Alpha 1 calcidiol. No, alpha 1 calcidiol. Can you say another name?
Calcitriol.
Calcitriol. Okay, what do you mean by calcitriol? I think your answer is correct, but I want you to say it. Can you give me two numbers?
Numbers.
125.
1 and 25. Yes, 1 and 25 dihydroxycholecalciferol. I want 1 and 25 dihydroxycholecalciferol. If we have a nutritional deficiency, I can give 25 only. 25 vitamin D, 25 hydroxycholecalciferol. But here, I must give 1 and 25. Why?
Because the kidney will be converted from from 25 to 125. So in this case, they got problem with the kidney, so cannot convert.
Very good, fantastic. This is the answer. This is the answer, yes. So normal kidney has 1 alpha hydroxylase. You take 25 hydroxy vitamin D, converted in the kidney to 1 and 25. But in this case, di mana? Can I take 25? Di mana? Convert. Tabu leh. So you must take activated 1 and 25 dihydroxycholecalciferol. Okay, very good. Carry on.
Thank you. And then for anemia, as I said before, that anemia in SCD is mainly the result of erythropoietin production decrease, right? And so, but this usually manifests in patients with stage 3 to 4 SCD. But in patient with later stage, we need to give recombinant human erythropoietin as their hemoglobin level low, so that this will decrease the need of transfusion to the patient. Okay. And then for hormonal abnormalities, as children with CKD will have growth hormone resistant, so they will have high growth hormone but poor growth. So we give recombinant human growth hormone so that it can improve their growth up to 5 years.
Okay.
Then we treat the underlying disease that happen. For example, hypertension. So we give salt restriction diet, and then we can also give diuretics to the patient, thiazide and also the diuretics. And antihypertensive medication can also be given to all children. But we need to monitor the renal function and also electrolyte balance closely with this patient. Or immunization. So the role of immunization, actually all children with CKD must receive all the standard immunizations according to the schedule. But there is an exception to the immunosuppressive children. So we need to withhold the live virus vaccine such as the MMR vaccine in children, as it will further enhance the virus replication.
Any other vaccine? It is not live attenuated, but you need cautions when patient has chronic kidney disease. It's given in Sarawak. One vaccine is given in Sarawak.
Yes.
Yes.
Japanese encephalitis.
Japanese encephalitis, very good. So Japanese encephalitis, it is not live attenuated. It is killed vaccine. But there is precaution for patients with chronic kidney disease. I don't know why, what is the mechanism, but it is mentioned in pediatric protocol that when you have chronic kidney disease, be careful from Japanese encephalitis vaccine. Okay.
And then lastly, for dialysis and transplantation. So in stage 5 CKD, the optimal management is renal transplantation. But it is quite difficult to get this procedure done. So because children need minimum of 10 kilograms of weight before transplantation in order to avoid renal thrombosis. But if the transplantation is not possible, we need to do dialysis. So there are 2 dialysis that can be done, which is the first one is peritoneal dialysis and then hemodialysis.
Okay.
Okay, so and then lastly for the prognosis of CKD children, those with marked CKD, which is stage 1 and 2, they are good, but they need to be monitored for the progress of the kidney function. And then those with stage 3 and 4, they will likely to progress to end-stage renal disease. But and then for children that has undergone renal transplant, the prognosis is good, but they need to take immunosuppressive medication, which has more side effects. So we need to treat the side effects. And then lastly, children on maintenance dialysis will have the highest morbidity and mortality because they have to spend the whole life on dialysis. That's all.
Okay, very good. Okay, any questions? Okay, if no questions, we go to the next presentation. Try to be faster, try to finish in 15 minutes because we have a meeting at 5:15.
Prof, I have a question.
Yes, yes, please.
Actually, my question would be two. First and foremost, in terms of the management of CKD, may I ask why in pediatric age group we don't restrict the protein intake, whereas in adult, in CPG mentioned that we need to restrict the protein intake because protein is toxic. And then the second question would be that when do we do the parathyroidectomy in cases of the apa nama ni? Tertiary hyperparathyroidism just now. Thank you, Prof.
Okay, difficult question is the first question, protein restriction. There is protein restriction. Who said there is no protein restriction? There is protein restriction. Protein increase burden on the kidney, so always there is protein restriction. Yeah, always there is protein restriction. Regarding yes, please.
Is there any amount, maximum amount of protein per day, Prof, for patient with CKD in pediatric age group?
About the maximum amount, I'm not sure. Usually we refer to dietitian, and there is a certain formula called Nibro, certain type of milk called Nibro. The Nibro has special structure which is useful for kidney disease, and it has the right amount of protein. The other question is, you said parathyroidectomy. I never read about parathyroidectomy for chronic kidney disease. Did you read it? Read it somewhere?
I sometimes found a case in surgical ward. So, but I did not find any description of that procedure in Nelson. So I was just wondering, what's the role of using that surgery? Is there any role in pediatric age group?
Parathyroidectomy. I don't know. I need to go and read. Yeah, I need to go and read parathyroidectomy. Yeah. What we know that thyroidectomy, yes, and it happens when you do thyroidectomy, you also cut the parathyroid. That time you need to give supplements for the patient. But to go and do parathyroidectomy itself, I never read about it.
All right, thank you, Prof.
Okay, welcome. Okay, any other question? Okay, we go to the next presenter.
Okay, so I'm going to be the last presenter. So I'm going to present the enuresis. Okay, so this is my outline for the presentation. So first will be definition, second etiology or causes of the enuresis, classification, and finally the diagnostic approach, which we can cover the history and physical examination, investigation, and treatment. So for the definition, so based on the up to date, so enuresis can be defined as the discrete episode of urinary incontinence during sleep in children in the age of 5 or more years. And then according to the article titled Primary Nocturnal Enuresis, enuresis can be defined as the voluntary or involuntary wetting of clothes or bedding with urine for a period of at least 3 consecutive months in children older than 5 years of age. Next. So let us look at the normal voiding. So basically in fetus, the normal voiding occurs by reflex bladder contraction in which there is simultaneous contraction of the bladder and relaxation of the sphincter. And then the urine storage usually results from the sympathetic and pudendal nerve mediated inhibition of the detrusor contractile activity, which is accompanied by the bladder neck closure and the proximal urethra with increased activity of the external sphincter. For infant, usually they have already coordinated reflex voiding in which as often as the 15 to 20 times per day. For the children at the age of the 2 to 4 years old, they are already developmentally ready to begin the toilet training. However, to achieve the conscious bladder control, several conditions must be present in which first, they must become aware of bladder feeling, means that they must have conscious awareness of fullness. And second, they can develop the ability to suppress the detrusor contraction voluntarily. And third, they learn to coordinate sphincter and detrusor function, means that they are able to postpone voiding by suppress the urge to void. Next. Okay, so basically these are the list of the etiology or causes of the enuresis. So first, we can look at the delayed maturation of the cortical mechanism, in which they allow the control of the masturbation reflex. Second, defective sleep arousal means that the child have difficulty to arise from the deep sleep. And then third, reduced antidiuretic hormone production at night, in which result in the increased urine output. So the child may have nocturnal polyuria. And then next factor is genetic factor. And then next can be caused by the bladder itself, which is the lack of inhibition, reduced capacity, and also bladder overactive. And then next causes is constipation. It's believed that when there's a fecal retention, it can cause reduce in the bladder volume. Okay, and then another organic causes, for example, like UTI, obstructive uropathy, or sickle cell anemia nephropathy. And then the sleep disorder, and also sleep disorder breathing secondary to enlarged adenoid, and also psychological factor, which is more often in secondary enuresis, in which that the child may have stress such as trauma, abuse, or parental conflict that can lead them to have enuresis. Okay, next.
Can you go back to the previous slide? Psychological factors. So this is common. And another thing I think I didn't see you mentioning it is child sexual abuse. Yeah, because when the child gets sexual abuse, sometimes the child is not able to tell. Yeah, he gets shocked that someone abused the child sexually. So the child is hurted, feeling pain, but is not able to tell. Is not able to tell his or her mother, his or her father is not able to tell about the perpetrator, and the perpetrator sometimes is from the family, sometimes the father himself is the perpetrator. So the child will have a lot of stress. So this may manifest as secondary enuresis. After adequate control of the sphincter, it may present as secondary enuresis. And you mentioned organic disease, urinary tract infection, obstructive uropathy, sickle cell anemia, nephropathy. What other organic disease? Any other organic disease? Open question, any other organic disease? We see in clinical practice? Diabetes. Yeah, diabetes. When you see secondary causes, think in diabetes. Yeah. Okay. Carry on.
Okay, so for the classification, enuresis can be classified into the monosymptomatic and non-monosymptomatic. For the monosymptomatic, can further divided into primary and secondary enuresis. Okay, so for the monosymptomatic enuresis, means that the child with enuresis without any other lower urinary tract symptom and without history of bladder dysfunction. So it can be divided into the primary and secondary enuresis. So usually the monosymptomatic enuresis is more common compared to the polysymptomatic enuresis. For the polysymptomatic enuresis, it is enuresis with other lower urinary tract symptoms, for example like urgency, distency, frequency, daytime incontinence. And also usually can be caused by the bladder dysfunction and also bladder and bowel dysfunction. Okay, so for the monosymptomatic enuresis just now, we can further divide it into primary and secondary. So the primary enuresis in which the children had never achieved a satisfactory period of nighttime dryness. So it is a common, which is 75 to 90% children. And for the secondary enuresis, children usually develop enuresis after a dry period of at least 6 months. Okay, so for the primary enuresis, usually more common in boys compared to girls, which is 60%. And usually children with primary enuresis have strong family history, in which in 50% of the cases. Some children have not established total bladder control and will wet their bed once a week or more. And majority of the children have no underlying organic cause. Usually they have the delayed activation of the bladder control mechanism. Okay, for the secondary enuresis, we need to have a careful history and investigation because we tend to get the probable organic cause. So usually the children with the secondary enuresis may have daytime wetting, can be usually caused by the bladder distrusor instability. And other possible organic causes like urinary tract infection, spina bifida, diabetes mellitus, and also behavioral problems as well as abuse, as explained by Dr. just now. Okay, so we move to the diagnostic approach. We will get to see the history and physical estimation, investigation, as well as the management. Okay. For the history, we need to ask the parents during the daytime wetting or any other lower urinary tract symptoms because we want to look if there is any urology or neurology problem and any prolonged period of dryness. And then for the frequency and the trend of nocturnal enuresis. After that, we need to ask regarding the fluid intake. Is the children take more fluid during the late evening and then tend to bedwetting during night. And then for the stooling history and history of swallowing. And also we need to ask the medical history if there's any underlying diabetes, mellitus, UTI, any sickle cell disease. And also we need to ask regarding the social history because we tend to have the psychological causes of the enuresis, and then behavioral history and also body diary for polysymptomatic enuresis. And then for the physical examination, usually there's no finding, but we need to do to exclude the other causes. For example, like we think of renal disease, the patient may have poor growth and also hypertension. If we think that this patient may have obstructive sleep apnea, the sleep disorder breathing caused by the tonsillar hypertrophy. And then there is a detection of wetness in the undergarment. It's a sign of daytime incontinence. And then the palpation of abdomen, if there is a fecal continence, but usually fecal continence cannot be palpable. Okay, and then perianal exploration or vulvovaginitis can be caused by the pinworm infection. And we can also do rectal examination after voiding in order to assess the possibility of chronically distended bladder and constipation. And also we must look for any neurologic and spinal abnormalities that can cause the enuresis. Okay, so for the investigation, we can do urine analysis to look if there's any glycosuria and then look at the specific gravity and the osmolality. And then we can also do urine culture and sensitivity if there is any presence of white blood cell or nitrites. And then we can also do the ultrasound of the renal tract to look if there's any renal tract abnormalities that cause the enuresis. And also we can do the avoiding cystourethrogram, any anatomical abnormalities. Okay, so move to treatment. Usually the primary monosymptomatic nocturnal enuresis, it has high rate of spontaneous resolution. Okay, for the primary nocturnal enuresis, we can use one or more treatment. So we can treat based on the indication and reassurance. So this kind of treatment give the high rate of spontaneous resolution in the children with enuresis. And then second, we can give children motivational therapy example, like we advise the parents to give the sticker or star chart to the children if they manage to getting up at night, and then to prevent backbiting. And then enuresis alarm is the most effective counter therapy. It will be explained later. And then the small pressing is very effective, but in the short term. Example, like the children want to sleep over or holidays or during the camp attendance. Okay, for the secondary nocturnal enuresis, we must treat the underlying causes as stated just now. So for the education and assurance, okay, so we must educate the parents especially that say that the enuresis is common and it can result on its own in the majority of the children. So advise the parents to avoid the parenting measure because this kind of parenting measure can affect the child's psychological development. And then using the back protection and washable disposable product. So easy for the parents to clean if the child has backbiting. And then keep calendar of wet and dry nights and void regularly. So ask the parents to teach the children to void regularly during the day and just before going to bed. And try to avoid children to take high sugar and caffeine based drinks and minimize the food intake during the late evening before they went to sleep. And then for the motivational therapy, keeping a record of the progress and give rewards, either as penalty to the children. Okay, next. Okay, this one is the enuresis alarm. So this kind of management actually, there's a lot auditory or vibratory alarm is attached to the moisture sensor in the underwear of the child. So actually this alarm is used to be activated when the voidings occur. So the intention is to awaken your children and alert them to wake up from sleep to void, go toilet to void. Okay, so next is pharmacological, which is the desmopressin. It's actually the synthetic analog of the anti-diuretic hormone, usually given orally to the child in the late evening in order to reduce the oral production during sleep. And then this kind of pharmacological therapy only achieve the suppressive effect
Shahira, we can't hear you. Shahira?
Sorry, doctor. Currently, we have a problem with Mahala's internet.
I see, I see.
I think everyone is trying to use their mobile data.
Okay, okay.
Sorry, doctor, we have a Wi-Fi connection problem at our hostel.
No problem, no problem. I think you have a few slides and you will finish, is it?
Yeah, only I think 1 or 2 more slides.
Okay, fine.
Doctor, should we proceed or we want to wait?
You continue. You continue.
Oh, okay. So this is actually the last slide. No, another one. Okay, so for the pharmacological just now, desmopressin actually is a synthetic analog for the antidiuretic hormone. It can be given orally to the child in the evening in order to reduce the oral urine production during sleep. And then this kind of therapy actually only achieve the suppressant effect rather than a lasting cure for the child with enuresis. Okay, next. Okay, so other than desmopressin, we have anticholinergic, which is the oxybutynin, in order to damp down the bladder contraction, as explained by Dr. just now for the first presenter. And then we could also use the imipramine.
Very good. So you still remember, huh? You still remember? So can another one remember oxybutynin? Other than Shahira?
Yes, doctor.
Yes, tell us.
It is an anticholinergic that relax that cause the muscle relaxation and increase the capacity of the bladder.
So it is used for which condition?
Can use in spina bifida patient.
Okay, it is used along with
Neurogenic bladder.
neurogenic bladder. Yes, it is used along with
CIC.
CIC. Yes, CIC. Clean intermittent catheterization. Very good. Very good. Okay, carry on, Shahira.
Okay, so last one is the imipramine, which is the tricyclic antidepressant. It's a mild anticholinergic and alpha adrenergic effect in which help to reduce the urine output slightly and also may alter the sleep pattern of the child. Okay, so I think that's all for my presentation.
Okay, thank you. Any questions?
No, doctor.
No.
Okay, so yes, if no questions, all the best for you, inshallah, and see you soon in the world to do the short cases.
Okay, doctor.
Okay.
Thank you very much, doctor.
Welcome. Thank you. Thank you. Bye bye.
Bye bye.
Bye.
Thank you, doctor.
Thank you. Thank you.
Seronok ni sah. Bye.